So many people are looking to live happier, more stress-free lives. We provide interviews from mental health experts across various fields because we know finding quality information isn't always easy. Let's find more sanity together. Hello, and welcome back to the second episode on telehealth psychology and consideration. Again, we have Dr. Mary Alvord, who has been doing telehealth for a very long time, knows a lot about the topic, talks about ethics around the situation, logistics around it, and so we're going to keep moving through this conversation. Last episode, we were talking a bit about clients that this is useful for, so I want to give more examples of why telehealth has been so useful for certain classes of clients, but also talk about where it's not maybe necessarily appropriate. And one type of client that I was thinking off the top of my head while you were talking about different clients it might be useful for, where I find in my practice, because I have a lot of people in their late 20s, 30s, early 40s, is new parents and new moms. And them being able to actually come to therapy where they might not have in the past been able to because they do have an infant. And they could be right there. They could have the baby on the baby monitor. They could have the baby in the room, and they could still get the mental health treatment that they want, potentially during one of the most stressful moments that they've ever had in their life, which is something very precious has been given to you, and it's your very first child. Any other thoughts of people that we're able to help in a new way because we have telehealth at our fingertips?
Well, I'll just add a little bit to that. I also, work with parents, children, teens, and then I'll talk about some of my older patients. But I've had parents who've not been able to come in person because a child is home ill. And we may shorten the session to 30 minutes and don't place value on it, but they may put a video on so the child can be occupied during that time within eyesight, and they can care for the child, but then we also have continuity with therapy. So it helps in so many of those situations. Others, I have had, some people have had surgery and have not been able to drive for, let's say, 4 to 6 weeks. So temporarily they can then switch to telehealth, or maybe they're in a different spot and it's just not as easy to get in logistically. The other clinically that, we really can help sometimes are people with social phobia as a starting point. So I have found some socially anxious kids who we may actually have to start with the chat function, but I see them. And it's part of the hierarchy until they gradually can get into the office. So I think various barriers that exist are really, it's a potential gold mine for people, as well as accessing specific services. Like I do a lot of work with OCD and social anxiety, and not every region has a specialist. And so people can really benefit from getting those specialized services. Or, we will refer to other people with specialized services, more trauma focused, or the PCIT, which we have interaction room that we set up a camera and a microphone and all that, with the Bluetooth. But now we're really using it mostly for with telehealth because it's in the home. So it can benefit so many. I don't know if you want to jump into who might not.
Just another group I'm thinking about too are caretakers, people that might have elderly parents that need to be, or a partner or a child that they need to be at home for.
Right.
And we know that there's a whole line of research around caretaker burnout and mental health, because being a caretaker can be an incredibly stressful and grinding task. And we could provide treatment for people who taking the stress of who's going to watch mom while I drive to the therapist's office.
Right. Yeah, and to add to that, I've worked with people whose family member was in the hospital and they really needed support, especially during that time, and they could step outside of the hospital and do a session and have continuity and get the support and work on whatever it is that they needed. So the other thing is, like, for teens, sometimes they can't get a ride, just plain old logistics, right? And the other thing that we did talk a little bit about, but we'll talk on air, is people who perhaps need sign language interpreter or a foreign language interpreter. And while there are transcription services now that can be plugged in immediately to the video platform, for some people they want more of having a person, so you can actually hire somebody to do some sign language, because as mental health providers, with the ADA laws, we are required, if somebody cannot hear, we're required to provide services in a means that they can access. So keep it in mind, it's a lot less expensive to hire somebody just for the time of the session, whether it's another language or sign language interpreter, rather than having someone travel to do that.
And I do want to jump into more ADA considerations, but yeah, I wanted to, my CBT mindset, I always think about anchoring. Like, before we talk about all the clients it's not useful for, let's just ping the clients that it is useful for, just not to pull some sort of mental bias against it. So what are clients that you found that is probably not best to do telehealth for?
Well, definitely someone who is agoraphobic or isolated, because that is the opposite of what they need. They really need to come out and see you in person. And for the agoraphobic, they need to leave their house. So part of the hierarchy might be small steps in getting them to the office, but that needs to be the goal. I'd mentioned people with substance abuse. Sometimes it can work better in person because you have all of the senses that you can pick up on. And age. So for what we have found in our practice is the young kids have a really much harder time just staying focused. And I'm talking 5, 6, 7, 8-year-olds. It's hard for them to stay focused on a virtual camera. That's why education system suffered so much for the younger kids, because they couldn't do virtual school all day long. They could barely do it for 30 minutes. So who it doesn't work for, I think it's factors you need to take into consideration. The age. I also look at diagnoses. And for some kids, I think about some of the, not to be biased here, but some of the ADHD middle schoolers that I have, and they're on several tabs at the same time, and all of a sudden their face turns green. And I'm like, okay, what tab did you on? Because your face turned green. Now you turned blue. So please close the tabs. So they just have a hard time staying focused online, and there are just too many distractions. So I'm not saying for everyone with ADHD, but I have found that we really do need to assess and see with whom does it work. And so for those kinds of kids, we pull them in. For kids who need more visual guidance, concrete examples, the proximity control, behavior management, those all don't do better. I have some older people who just prefer not to do telehealth. They just like the in-person contact. And perhaps for some of them, it might be they are more isolated. And so those are some considerations, because I think across the board, you can make it work. Don't think of it as a all or nothing, right? We think about, thinking habits, right? We need to look at the continuum. So it can be sometimes virtual and sometimes in person, and really have a hybrid model, which I like having that mindset. For people who have telehealth only practices, that is an issue because ethically we need to do what's in the best interest of the client and not in just what we want or what we prefer. And we are perfectly within our rights to offer that, but then we have to have options. We have to have a good method of differentiating who is doing well at which time for telehealth, and then have maybe an office that we rent a few hours a month that we can then see them there, or perhaps we refer out, or we just have backup plans for whatever that might be.
One time I had somebody log in on their phone while they're driving and had propped it on and I was like, no, 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 no. We are not getting into a car accident doing it like this. We'll reschedule. Not that, I mean, if somebody has a driving phobia, it could be very powerful being on the phone and then having them do an exposure while they're driving. And it means that back in the day, you would have to get in the car with them.
Right.
Versus now you could do it more effectively. So it's not that necessarily doing therapy while in the car has to be problematic, but FaceTiming while driving is generally not a good idea.
Right. And the same goes for people who are driving and perhaps they are the passenger and they're trying to do their session. We have a talk of, again, getting back to who's in your space, what is private? How, is this going to interfere with the session? And even with headset, it helps because then the other person doesn't hear what the clinician says, but they can hear everything the client says. Mm-hmm. So I will say, you need to pull over and get out of the car because, it's just not only is it distracting for the driver. What if your teen says something that's really upset and you're the parent driving, right? And they say something, you get tense and it takes your focus away. So it's also a safety issue.
Mm-hmm. Let's talk about cultural considerations that we should have when we're telehealthing into people's worlds.
I think cultural context and competence and just considerations are critical always, whether we do in person or virtual. But I think it's even more critical with telehealth because we're often going into communities where we don't know, what the values are, what resources there are. And so I always ask, and partly because I'm originally a New Yorker and did not speak English growing up, and no one in my neighborhood grew up speaking English at home. We all had English as a second language once we were in school. So I'm very sensitive to language. What language or languages are spoken in the home? What is the attitude about mental health? My father was from Russia and long ago, but his vision of mental health was, I don't know what, but he was very upset when I said I wanted to be a psychologist. And so what people's views are on mental health and what it means to them as a family, but as a community and ethnically, what are those cultures that your client is in or facing? Or many kids who are in dual cultures, they're assimilated, but their parents are not. They're serving as interpreters, perhaps, for their parents, or just interpreting the world around and have very different views. So part of what I talk about with value, with culture is what are the values? And I get back, what's important to the family and how do they value or look at mental health services or mental health impediments? What is getting in the way and what is their view of that child, teen, or adult? So we always need to look at the context. And actually, TFCBT has done some research on that in terms of different ways and different cultures expressing the trauma, whether it be more somatic or more cognitive. So there's some interesting research on that as well.
Have you come across anything about actually someone being in someone's, say, house versus office, that you have to take a different consideration so you're not violating somebody's cultural rules or norms?
Yeah, I had a family where they lived in a small apartment, and so
Mm-hmm.
logistically it was difficult for this team to have privacy, and they also felt like there shouldn't be any secrets. So we had to really define what they felt safe discussing and not safe, and then not insult sort of the family, and make sure the family was included in some way. So we had to do a lot of workarounds in terms of including. I think I've always worked from a more systemic level, and so I like to include families, caregivers, but not the whole session typically, especially if it's a teen and they need the privacy. So you do need to know, what is the living situation, and who's coming in and out, and who thinks they should know everything about you, especially if they're paying for it with some, this family, or we're paying for it, so we really need to know. So,
So you had brought up some ADA considerations. Any other ones on the top of your head that you think that we should know of,
well,
besides the translating service,
yeah,
the sign language
well,
service?
I think, just wheelchair accessibility, or walker accessibility. If your office does not have a working elevator, so I've been in a building where the elevator didn't work, so it didn't really help. A working elevator or other means for people to get down, then you need to make sure either that there is something they can access the office, or then telehealth would certainly help with that barrier. I think the language, the hearing, and just the physical accessibility. The other thing is, nowadays it's so wonderful that we can have different languages. So if somebody's fluent in English but not quite, completely fluent, we can use the subtitling or transcription services that the telehealth platform may have. Because I've had a few clients over the years whose primary language was not English, and when they got upset, they could not think of the words in English. They could only think of it as in their native tongue, and so
Mm-hmm.
it can really it's just another sort of cultural, but also it's not quite a disability, but it's a barrier that we should consider. So those are the ADA that come to mind.
Also, I mean, this is a little bit off, but the language, if someone is multilingual, the language that they're thinking, so say you're doing a trauma narrative,
Hmm.
or thinking about a distressing memory or thought, what language they think in could impact their emotional arousal and their processing of it. And that's actually a nice service as it gets more automated, to allow people to use the language that they need
Right.
and still be able to work with a therapist that doesn't know their secondary or tertiary language that they might be using.
Right. Yeah, and I think we need, we are a multilingual country. We have people from all over the world and need to be sensitive. And absolutely, people can think, particularly when they are distressed, in their primary language. Or for some of my clients who may have some cognitive decline, they seem to go back to their primary language. So consider all of that.
You had mentioned to me that there's some changes in insurance coding when it comes to telehealth that has been a recent modification.
Right. So when we started telehealth, we used modifiers. Say for a 45 individual 90834, we would put in parens GT. That then was replaced by 95, which we have been using up until January 1st, 2024. Medicare, which really sets the insurance standards, came up with a statement saying that you no longer needed to use the modifier code, that you simply needed to use the location code of 10 or 2, 10 being, at home, or 2 being in a facility. And so that's sort of the way their regulations now were written starting January 1st. The reality is that it is not being adopted across the board, and many people who participate with insurance or clients who then submit, those are being rejected. So I would say in the year 2024, find out if you are submitting, or let your clients know that there have been some changes, and that you really need to check with the insurance. My practice at this time, we're using both. We're still using the 95, and we're using the location services figure. More is better, but that is the new CMS regulation. So we'll see. Follow it. Also, audio only has a modifier code of 93. That has been approved to allow audio only, I think, until the end of 2024. And hopefully they will continue, because we haven't really talked about it, but sometimes people can't get their video to work, or they're not in a place where they, have video, or they want to use their phone and their phone is running out of juice. And audio is much less taxing. And so there is a code for that now, and it's considered telehealth.
Okay. And just going back to the comment I said before, it's really hard when you're in a small business, or not even in a small business. I mean, just staying up, because it's not like an email goes out and says, "Hey, everybody, guess what? We changed the way that we're coding these things." So, and it's March 1st right now that I'm recording. So it's been 2 months.
2 months, and it's still not worked
since it
out.
happened. And I just learned this today. And meanwhile, I code patients every single day that I'm seeing, and my whole practice does.
Right.
So thank you for letting me know. But I wish that it was a little bit maybe somebody listening will create an alert system for all of us that will start.
Well, I'll put in a plug for 2 organizations to really consider joining and being on the listserv are your state association, because often the state associations, you're in New York, I don't know if it's been discussed, but it's been discussed in Maryland, the changes in code. We have a professional affairs officer who tries to keep us abreast of some of these, because it's very difficult. The other thing is APA has a division specifically for independent practitioners, Division 42. And I don't know for sure, but some of the APA divisions you can join without joining APA. So it's more affordable. So consider those. I have a hard time and this is I give lots of talks, so I try to keep up with telehealth, because, for 10 years, I've been intensively involved with telehealth, and the landscape changes, the codes change, as well as the states that we can telehealth into. So the other thing I will say is that, a little bit off, but interjurisdictional practice, if you are if you've got someone going somewhere else, check with that board, because some boards actually allow, even if they're not part of SIPACT, they allow telehealthing in or out, and then check with your own state.
Yeah, and I want to also pull out a psych pack, because psychologists could do that, but we have many other people in our professions that can't get psych pack,
right?
At least not now. And so every single state has different regulations about telehealth providing, whether you need to get a permit, whether they permit a certain amount of days that you could do it as an out-of-state license if you're not allowed to do it at all. And what I've found useful is actually calling up the board itself,
Right.
which can be difficult because you call up and they say, please call back on Tuesdays and Thursdays between the
Mm-hmm.
hours of 1 and 1:30. I'm over exaggerating, but they limit the time when you could actually call. Sometimes when you email, people will email back, so that's another good way to do it. But that's how I found how to figure out what am or am not allowed to do
Right.
when someone's out of state.
Right. Because remember, to be compliant, we have to be either licensed or have permission to telehealth between where we are and where the client is physically located, not their residence. And this applies to college students, and many people think just because the college student has a legal residence in your state that it's okay to see them wherever, and that is not the case. The other thing is, the world is becoming more global. So
Mm-hmm.
you need to check too if someone is going abroad. Many of the European Union, uh, they have certain license regulations
Yep.
that you may or may not allow. Other countries don't have any, but you need to
Mm-hmm.
you need to do your due diligence and at least ask, find out, and document.
Yeah, I did that. I did that where somebody had a family member in another country, and you needed to get a permit in order to do that. Where other countries don't
Right.
have any limitations. What in the situation where you have let's say one family member in New York and one family member in Florida, and they want to do telehealth, but you are licensed in New York.
Well, hopefully New York will get into Psych Pack soon. I know it's in the legislative phases right now.
Mm,
Um, but you need to contact each state. I mean, you
mm-hmm.
you know, you can't just assume that you can do it. So those of you in New York in particular, not or any state that's not part of Psych Pack, you're more limited. But as Jason said, call the board and find out. The other thing is, I would say if there's an emergency situation, documentation is always critical, right? So if you know, I was in a session, um, and I found out, even though I said to the kid, "Where are you?" At my grandparents' house, and because it was different, I didn't realize they were in a different state, and um, because we were dealing with the crisis, the grandparent had died suddenly, and the family swooped him up and took him, and he had a session. Um, I just documented that it was urgent, that I didn't know, and this was the situation. I was covered, but just to cover my bases, I also just documented. So documentation can go a long way.
Well, let's talk about crisis situations because I promised on the last episode that we would
Right.
get there, and it's critically important. When somebody is in crisis in their office with you, there's a lot of control and a lot of steps that you could take to mitigate that. Where if somebody's in crisis on telehealth, they could literally grab the laptop screen and just slam it down, and then they're just instantly gone. What are the precautions or considerations or steps that we should be doing in order to be prepared and ready if there is a crisis over telehealth?
This is where I think that a specific telehealth consent agreement becomes critically important, which needs to contain crisis number information. If they're in college somewhere else, what is there a mobile crisis unit? Is there a health center? What resources are there? In addition to other providers, information, phone numbers, how you can reach them in an emergency, and then um, someone, an emergency contact, whether it be a family member or a friend, and that gives you permission immediately to contact them because it can happen that someone just I was going to give that example. I had somebody just slam the laptop shut and would not answer the phone and could not get hold of them. And so we had to then, I was on the phone calling one person, and I have a front desk person who then was calling someone else so that we could try and make sure that we had someone who could check in on this person. It was not
Mm-hmm.
in emergencies, and he wasn't suicidal, just angry. And but if there is a suicidal high risk case that you need to get someone checked, you need to have all those numbers, and you need to know their location, because if you call 911, or then even 988, but 911, they don't know where to go unless you have an address. So
Yep.
you need to have the address where they are on that consent form, and also the address of perhaps an alternative, if they have an alternative location that they're frequently at. So you have it at your fingertips.
And I'm not a 911 expert by any means, but when you call 911, it's usually local.
Right.
And so if somebody's in Minnesota and you call 911, you're reaching, for me, the Manhattan
Exactly.
area, and they may or may not be able to
Right.
get you connected. So that is something where, even though it's an extra step of work, knowing the local number, if somebody's going to be in a
Right.
place consistently doing telehealth.
And I put the work on the client. So I'll say, you need to find out what the number of the crisis center in the area you're at. And then I'll double check it. But I want them to also be aware, because they're the ones signing the agreement, and they're putting this number there. So we do the best that we can. With all of this, we're learning, and we're problem solving. And when we do high risk assessments, we're looking for the protective factors. We're looking at the risk factors. We're looking at what's keeping them going and who's there to support them. So I always do kind of who's part of your support team. And that's just the way that I do therapy is, what are your values? What's important to you? And who's part of your support team? So I know who they might reach. If they're really angry, who might they reach out to? And then I try to get permission for at least one or two people that I could contact.
And just with everything new, advancements come over time. Sometimes because something happened and people are being retroactive. Sometimes it's proactive. So I can imagine in the future, like that 911 situation I was talking about, that it would be able, in some way, that's going to be ironed out in some fashion, hopefully where it's easy to direct to a location depending on who you're talking with. I also, and this is probably a much bigger conversation than now, is the idea of free market principles, right, with competition, where when you're opening up borders and you're opening up price points of the clinicians that people could see, free market principles then interact with the business side of anything.
Right.
Of any, and that's like the NAFTA agreement with Canada and Mexico and free trade and all that. So I'm really interested to see. I think we're going to have growing pains around free market principles and the practice, private practice, even hospital practice. I can imagine while they're doing telehealth. So there's a lot of unknowns, but also it's good that there's going to be a lot of change as well.
Correct. And there, just to make a point about that, people are also questioning, like, which insurance company, like if you're doing telehealth, and if you submit, where do you submit? How do you submit? So there's just a lot of questions around that as well.
Well, before we jump off for today, any other last thoughts about considerations people should be having about doing a telehealth? I mean, everybody's probably incorporating telehealth in their practice, but if it's somebody that's going into their own business or they're graduating soon and they're going to be doing this more often.
Well, I would just say we didn't really talk about sort of some of the basics. Just get good equipment.
Oh,
Get a good webcam, high definition webcams, and a high quality platform, because that's your office. And so make sure that you have all the capacities and the broadband width, and use the router instead of Wi-Fi, because
yep.
that's going to be better for streaming everything. And then I just think it's a mindset. If we can think sort of the continuum and not just think all or nothing, we're going to do our clients best justice and ourselves as well.
I have two ring lights on my desk. That's why the camera and so well lit up, because I realized that for a year or two I had no ring lights, and I was my background light was brighter than me, and I was dark and not
Right.
looking so pixely, like I wasn't high definition, and the lights really made a difference. One last comment that I want to put in, and this is just reiterating something that you had said before, is that if you are doing a practice that's predominantly telehealth, or there's someone that you're treating that's far away that can't come to an office, and doing telehealth isn't what is the best interest of the client for their treatment, that if you can't accommodate it, then just like everything else that we do, when you can't do something as competently as somebody else could do, you should
Refer
refer
out.
out. And I just think it's an important reminder
Right.
for
You know,
people, because we might not consider it as much.
and actually, I hadn't mentioned this before, but many of the states still require intakes be done in person. So you need to
Mm.
check with your board of examiners for what's on regulation. During the pandemic, everybody, all the boards just said, just note it, in your notes that you're doing it because of the pandemic. But I think now that we're out of the pandemic, we need to make sure that like Maryland still requires in person, but they say if you say why you're doing telehealth and you're justifying it, it's okay. So be aware of that. I think regulations will change. Medicare is talking about requiring it every 6 months. So also
Mm.
beware. I'm seeing some clinicians advertising groups that they're doing for people in all 40 states of PsycPack. The other thing to think about is what are the regulations in terms of, and that's a longer conversation, but I will just state it here to think about what are the regulations reporting child abuse, elder abuse, duty of warn.
Yes.
So that's an important ethical, legal consideration that you need to be aware of as well. Which
And
it's overwhelming sometimes to think about all these different states,
yeah, yeah.
but you
And
need to know.
Tarasoff,
And
right?
Tara,
Some states are Tarasoff states, some states are not Tarasoff states. And
right.
so you need to know that as well.
Right. Because you don't want to
Um,
get into a conflict and then it's which state do you go by? Well,
mhm.
so
All right. Well, thank you so much for taking the time to
thank you.
talk about this, and uh, we'll be in touch.
Okay. And good luck to everyone continuing or starting a telehealth practice.